the body's ability to control glucose within the body. Glucose is required by the cells for energy metabolism, and glucose not enter the cells without insulin. Insulin is what connects to the cell, connects to glucose to help transport it into a cell. So diabetes is a change in that transport system. Either that the body does not produce enough insulin to carry glucose into the cells and then out of the bloodstream, or the body is not able to use the insulin that is there to transport the glucose into the body. So the glucose and insulin don't connect like they're supposed to. And that is the two main reasons for causes behind diabetes, either not enough insulin or inappropriate use of insulin. So keep moving you guys around because you covered up my slides. So our body makes insulin, a normal body makes insulin, and it makes it based on when we eat, enzymes in the gastric system then trigger the pancreas to release insulin. And so we see spikes at meal times, and then as the insulin wears down through the body, glucose is in the bloodstream rather than in the glucose is in the cells as insulin production reduces, and then we get hypoglycemia, which triggers enzymes and hormones to trigger hunger, and we eat again. So this is the normal insulin flow in the body. So there are four major types of diabetes. Type 1 and type 2 diabetes are the main ones that are discussed in adult 1. Gestational diabetes occurs during pregnancy. And then there is conditions that result in hyperglycemia or insulin resistance that are not specific to a chronic disease state, and they actually can be reversed. So again, we're going to focus on type 1 and type 2. In this course, you've talked about things like steroid use in pharmacology. You'll talk about diabetes insipidus when you get to adult 2, and gestational diabetes will be discussed specifically in family health. So kind of looking at the comparison between the two, type 1 and type 2, they have names that we used to call insulin-dependent and non-insulin-dependent diabetes. Those aren't necessarily fully accurate. And before that, we called them adult onset versus juvenile onset. Again, not fully accurate. Now, type 1 is more commonly diagnosed in younger people, but you can be diagnosed with type 1 at any age. And type 2, again, is more common in an adult population, but it can occur in children. And in the United States, we're seeing a higher incidence of type 2 diabetes as our obesity rate increases. Type 1 diabetes is an abrupt onset, where type 2 is more gradual onset. There's about 90% of the population has type 2 diabetes, and only about 10% of the population has type 1 diabetes. We think that type 1 diabetes is a link to an autoimmune disorder, maybe be triggered by a virus. Basically, what happens in type 1 diabetes is the pancreas stops producing insulin. The beta cells of the pancreas are destroyed and no longer produce insulin. And so that the autoimmune component comes into play. There's research that suggests, and we still do not know where type 1 comes from, but the autoimmune component is that the body recognizes, the immune system recognizes the beta cells of the pancreas as foreign and attacks them and renders them able to produce insulin. So that is the main difference between type 1 and type 2. Type 1 patients do not produce insulin. Type 2 patients produce insulin, either not enough or the body can't absorb the insulin that is or cannot use the insulin that is being produced any longer. And then what do they appear? So the appearance, whether they're fat or thin, is not fully suggestive of the type of diabetes they have. Type 1 diabetes patients tend to be more thin than obese, and type 2 patients tend to be overweight, but that is not set in stone. Symptoms, type 1, the 3Ps, polyuria, polydipsia, polyphagia, that is kind of the calling sign, classic sign for type 1. They also have a lot of fatigue and weight loss. And they have weight loss because their body is not able to properly use glucose metabolism, and so they then go into using fat metabolism for energy. And type 2, they can have polyuria, polydipsia, and polyphagia when their blood sugars are significantly higher, but they tend to just have kind of more non-specific symptoms. They get infections really easily, they're fatigued really easily, and typically are obese. It is more common to see ketosis, again, breakdown of fats and muscle. In type 1, again, they're not able to use glucose, so we see them start to break down fat and protein for metabolism, causing proteinuria and ketosis. And we will see this as almost a diagnostic tool. Patients will come in with polyuria, polydipsia, polyphagia, and some level of ketosis, and that's where diagnosis begins. Type 2, they may develop ketosis, but it is more rare. We see more often that they do not develop ketosis unless they are have a significant infection or stressful event going on. So again, type 1 don't have insulin. Type 2, they have insulin's not being made. Type 2, they do have insulin being made within the body, but over time, the body becomes resistant to the insulin that's being made, or the body is not making as much insulin. So a couple different thoughts there are adipose tissue surrounds the pancreas, and the production of insulin is decreased because the pancreas is being strangled by adipose. Also, the presence of adipose tissue prohibits the ability of the glucose and insulin enzymes to attach properly. So type 1 diabetics will require insulin therapy. Type 2 diabetics is not our first line treatment. It is usually our last line of treatment. A little bit about gestational, anywhere up to 10% of patients with who becomes pregnant will develop gestational diabetes. It has a lot of different issues go along with it. Typically larger babies because there's more glucose in their systems, higher risk for injuries and complications to both mom and baby, and then again, you're going to learn a lot more about this when you get into family health next semester, but there are specific times that we test all pregnant women for the presence of gestational diabetes. And then they should go on insulin therapy if diet modifications don't keep their blood sugar within normal. The oral anti-diabetics are not FDA approved, but we are seeing them used. And then we do see that once a woman has gestational diabetes, it does increase her risk for type 2 diabetes to develop sometime within the postpartum period. So again, we said there are other reasons that can cause kind of an acute diabetes that can resolve once the condition is resolved or the issue within the drug that's being used that's causing it is removed. So there's injury to that beta cell function within the pancreas. Could be for medical conditions like pancreatitis, which you'll learn about a semester, or drugs like the use of steroids. So once we fix those underlying conditions, that diabetes from that lack of insulin will go. Okay, so how do we diagnose a patient with diabetes? This is both for type 1 and type 2, and any diagnosis of diabetes. So they can have a hemoglobin A1C of 6.5 or higher. And who remembers what hemoglobin A1C is?
I think it measures it's a way to measure your glucose, your approximate blood glucose levels from like the past 3 months or something.
Correct. So it's going to give us a picture over the course of 3 months what their average is. So usually we say less than 5 or less is within normal, is going to be not diabetes. So 6.5 or higher puts them specifically into a diagnosis of diabetes. So they also have a fasting glucose of greater than 126, an oral glucose tolerance test of 200 or higher. So they drink this concentrated sugar, and then wait 2 hours and then check. If they are at 200 or higher, that is diagnostic for diabetes. You will see when you go into OB, into family health, that's exactly how we look for gestational diabetes. It's a stepped process. They take one test, that they fail that, they take another test, and then they're diagnosed. And then random plasma glucose. So they did not fast if that's 200 or higher. All right, so now speaking of that, if they just had a Snickers bar an hour before they had the blood drawn, but they have no symptoms of diabetes beyond that, we're not going to diagnose them with diabetes based on random glucose greater than 200. So we're going to get more history from that one. The A1C is probably what we're seeing most often being used right now, because again, it gives that 3-month average, which is give us a really good snapshot. So you guys went over glucose monitoring and foundations, right? Okay, so just as a brief review, there is self-monitoring, which is what we see most often. There's continuous monitoring, which is coming into favor. And then there is a difference between type 1 and type 2 testing. So self-monitoring is where they check their own blood sugar using the machine, the glucometer. Things that go in association with that, we want to make sure that they got it properly calibrated, that they know how to take blood sugar correctly, that they use either the side of the finger, or there are some now that allow for forearm testing that's specific. You have to have the right glucometer and the right strips to do forearm testing. You can't use any other. It's not calibrated to that. It's a different type of capillary blood. So we usually talk to them about using the side of the finger to protect the pad. We also talk to them about developing that first drop of blood, wiping that off, and then getting the second drop of blood is what we use. And the main reason for that is because we want them to have clean fingers before they start. And a lot of times it's going to be used, soap and water is best, but more often than not, they're using an alcohol pad to do that cleaning. And having alcohol present still on that first drop of blood can skew the results. So we tell them to clean the area, then do the prick, get the first drop of blood, wipe that off, get that second drop of blood, that's the one they test with. What we're expecting to see is that a patient that is using self-monitoring and they are type 1, we expect they're going to test at least 4 times a day. When they wake, with their meals, and then often also a 5th time before bed. That 5th time varies. Sometimes it's before bed, sometimes it's in the middle of the night. We'll talk about why they might do it in the middle of the night, 2 to 4 a.m. rather than right at bedtime. And typically there's not much time between dinner and bedtime results, so it's not as often we see at bedtime, but we usually will see some sort of nighttime or a 5th time. And it really depends on where, how controlled their diabetes is and what their A1Cs are looking like. Type 2, patients with type 2, it depends on how they're treating. If they're on an oral anti-glycemic or anti-diabetic, it's not super uncommon for the healthcare provider to let them test just weekly, or when they're not feeling well, weekly when they're not feeling well. It's not common to see someone who's just on orals to take their blood sugar as often as a patient with type 1. The caveat to that is if they are on insulin, they should absolutely be checking their blood sugar every time before they give themselves insulin. You guys remember me talking about that, or not me, I didn't have you. You guys probably remember KFC talking about that in your diabetes or your oral or your anti-diabetic PowerPoint and lecture. So when they monitor this, really kind of depend on their type of diabetes and what their healthcare providers' recommendations are. Continuous monitoring is becoming more frequent, especially with type 1, because they are needing to check so often because they are on insulin therapy. So that's actually a center place below the skin that they can then just place. It can go directly to their mobile device. It can go directly to their blood sugar machine, glucometer. If they have an insulin pump that provides basal and continuous insulin, those two devices can talk. They're becoming more frequently used. It's still really expensive therapy, and so it's sometimes insurance dependent. Okay, so we are not going to spend a whole lot of time on the glucose lowering agents because you spent an entire lecture on them in Pharm, and I do expect that you're going to go back and review that. It's a really awesome PowerPoint, so that tells you all about your anti-diabetics. This is going to be reviewed. So again, we're not going to spend a lot of time here. So we know that there are insulins that are injectable, that type 1s must use and may be needed for type 2s if they fail conservative management. And conservative management for the type 2 begins with diet and exercise modification, then moves into oral anti-diabetic agents, beginning with metformin. Then we might add a second oral anti-diabetic. And when those are not controlling the blood sugar, then we move to injectable insulin with the type 2. Now, when we add those, they don't take away oral antidiabetics. It's in addition to, so it's a stepwise process that we're adding. Okay. There's also non-injectables, and if you remember, most of them are specific to type 2 because they affect how the body uses insulin, but there are one or two that actually can be used for type 1 or type 2, not very many, one or two of them, and those are because they affect the way the body releases glucagon and creates glucose. So they affect glucose management versus insulin management. Those are the only ones that can be used for type 1. And again, type 1 is going to always be on insulin, and they might add this to help with even more strict control. So again, insulin therapy made from human insulins. We've got our the rapid, short, intermediate, long acting. That is something you guys have got to keep in your mind. And when you're talking about, onset peaks and things of that nature, am I going to need to know for NCLEX? These will be on here. Insulin will be on NCLEX. So if you learn that for that test and you dumped it, go back and learn it again. That is going to be something you're going to see over and over and over again. They are absolutely, it is absolutely vital that a nurse knows that rapid acting insulin can be beginning to peak within 15, 30 minutes and is out there. And it is, we've got to have food tray at the bedside if we're going to give a rapid. And that long acting insulin is 24 hours and doesn't have a peak. It just has it just has a duration, just kind of a 24 hour. Okay. So go back and look at those again if you did not, if you've gone and forgotten those. Basal bolus, this is becoming much more used now. The more evidence we find, the research is the more often that we can mimic the natural body, the better control we have. And so we saw earlier that insulin is released periodically throughout the day, normally from the pancreas along with eating. So we want to start to give insulin therapy based on that same principle. So patients not often have the traditional sliding scale of insulin. So sliding scale of insulin being where they check a blood sugar before they eat, and their blood sugar is 312. So then they go to this chart that says, okay, if the blood sugar is between 250 and 300, give them 7 units of insulin. So they do. And what we're doing there is we're constantly chasing high blood sugar, and we give them high spikes and dips. And so it's a very steep curve of we give the insulin, but it's just enough to cover what their blood sugar was before they ate. Their blood sugar is going to go up even higher with eating. So we're giving them high spikes and lows with that type of insulin delivery. We now are moving more towards an XY system where we don't only look at what's their blood sugar currently, but what are they about to eat? And can we actually provide insulin to cover what they're about to eat? Because we know the pancreas either is not going to cover it at all because it doesn't produce insulin, or it's not going to produce enough. We already know that. So we look at both what are they going to eat in terms of carbohydrates and what is their blood sugar. So we do a carb coverage and blood sugar correction. So I'm going to teach you that in the next slides. We've got another quick little PowerPoint, and that is something that we're seeing much more in frequency now than you see just a traditional sliding scale. The coverage of insulin that way is then hopefully getting them to that we give them a little spike for what they're going to eat, but they've got more in their system overall because we not only corrected their blood sugar, but we also covered for what they're about to eat, trying to act as a regular pancreas. So here is your chart like you had from farm. There might be, I'm going that way. These might be slightly different from your farm textbook. Questions, when you get questions about these through NCLEX or through our exams, are going to be well outside normal. So if you have to pick rapid, it's going to say the onset is somewhere less than 30 minutes. You wouldn't pick an hour and a half. It's going to be very clear. They're not going to be, so where intermediate says 1.5 to 4 and short acting is 1, you're going to get a time frame that's at 3 hours or 2.5 hours. It's going to be clearly outside the range from short to intermediate. Does that make sense? So our numbers there are going to be very clear if you get asked specifically about that. More often it's asking about patient safety. So you're about to give Lispro or Humalog insulin. What's the most important thing you have to make sure they have? Food at the bedside because they're going to eat. They need to have something to eat because this is going to be rapid onset. Or that you need to check their blood sugar before they get any kind of insulin. Or questions about they only have a long-acting insulin and are having blood sugar spikes. What type of insulin would you expect them to add? A rapid, short-acting, right? So those are the kind of questions you're going to see more often than not, and making sure that you understand which ones you've got to be really ready to have food available, or versus long-acting, which is 24-hour. That seems to be the most common question is, can you tell that you're giving a 24-hour insulin, knowing that that medicine won't help a blood sugar spike at the moment? So talking a little bit about storage of insulin, insulin can degrade in extreme temperatures. So they can keep it at room temperature for about 4 weeks. They want to watch the package inserts, especially when it comes to pens, because they're a little bit different, varying based on their chemical composition. But really for all insulins and all anti-diabetic, even injectables, they want to watch the packet insert, know that they can keep them out for a certain amount of time, and they do want to have them outside of the refrigerator for a good couple of hours before use. So they may get multiple bottles at a time, and they're good just sitting out at room temperature for about a month, the insulins are. So the others, they may get them a 3-month supply. Those others should be stored in a refrigerator that's not set below 32 degrees. When they pull out, because it's time for the new bottle, if they inject that insulin at cold, it's painful. It's much more painful. So we tell them to let it sit out for a couple hours because it's less painful when they actually inject. Sunlight is not good, extreme heat, extreme cold. So if they're going to be, so don't leave it in your car. You live in Oklahoma, this week for sure. But if they're going to be in a place where they're going to be out where it's hot, then they want to actually keep it in some sort of cooler. All right. Pre-filled syringes um, stored upright, and that's to help keep from any leakage occurring. And then for all insulins, rolling them rather than shaking them, and that avoids shaking. Some of the insulins can interrupt the chemical composition. Also creates a lot of air bubbles within the space, which makes it more difficult for accurate drawing. So when they are going to mix them, especially the cloudy insulins that need to be the particulates will drop to the bottom. They want to roll it between their fingers, between their hands, until that cloudy appearance comes back. So again, more review where they can do their injection site. It's important that they do subcutaneous injection. These syringes and needles, remember, are very small, so 90 degrees is absolutely appropriate for the sub-Q injections. Remember that regular insulin is the only one that can be given IV. The rest of them are sub-Q only. And that's an NCLEX question. I think every student I've ever talked to, including myself, had, which insulin can you give IV? Because it'll kill them if you give any IV. So another safety feature. And why do we want to move the sites around? What's the purpose of that?
Adequate absorption.
Mm-hmm. Really specifically, we want to avoid what we call insulin pockets, and that is where they get scar tissue developed from using the same site over and over and over again, and they get some scar tissue in there. Well, now they're injecting insulin into the scar tissue, which is not absorbed well, where fresh subcutaneous tissue is going to absorb it better. So that's exactly right. It's for absorption of that insulin. All right. Here, again, we talked briefly about insulin pumps. I had 19 students with type 1 diabetes in my in school that I worked for as a school nurse just before becoming an educator. And all but 3 of them had an insulin pump. And the 3 that didn't, it was insurance related. Those students preferred it. It is fewer sticks. They insert a needle subcutaneously, usually in their abdomen, or they can do it with their arm as well. And then it provides that insulin pump. That needle is then connected through tubing directly to the pump. They wear it like a pager, or put it in their pocket, and that provides them insulin, a basal rate of insulin that's set by their physician. And then as they take their blood glucose, the blood sugar readings before meals and before bed or at their nighttime check, they will either enter that information into their pump, which then gives them a bolus of insulin to cover their blood sugar and a bolus of insulin to cover their carbohydrate count. Some of them have that continuous monitoring, so those two speak to each other, and that provides them with that. Once they get past a certain point, it will give them that bolus, and that's set again by the physician when they get a bolus. And then they just have to put in there when they have their carbohydrates. Now, this is more often used in type 1s, but can be used in type 2 patients. So rather than having to poke themselves every single time they need insulin, that's already there. That system in place. So down to just poking their finger. And then if they have the continuous monitoring as well, then they're poke free, which is a big positive for them. The negatives are they are attached to a device. They are not waterproof. So they have to remove them if they go swimming and then reinsert them. So that's an extra stick. They can cover them when they shower. So tub baths are not so tub baths. And again, they're quite expensive. So and then it's an indwelling catheter, so they do have an increased risk for infection. I've not seen a pump infection. In the 3 years I worked there, nobody had site infections. Okay, so let's talk a little bit about some complications specifically to insulin therapy. So the Somogyi effect is where they get a high dose of insulin before bed, and then so based on their nighttime dinner, their dinner time blood sugar and what they're going to eat, they give themselves insulin. Well, that's also typically when they're going to take their 24-hour insulin. And so the two of those combined, the peak happens at the same time, and they end up with hypoglycemia. The body recognizes that and releases enzymes to correct that hypoglycemia during sleep. And so they wake up with a heightened blood sugar, but it's not from a lack of insulin, it's from an overdose of insulin when that peak effect is hitting. At rest, they are, when they're sleeping, their body systems are not using as much glucose, so higher amounts of insulin there also can cause problems. There's more, it uses the glucose that's there, and then there's extra glucose or extra insulin sitting out in the system. So the way to tell the Somogyi effect versus the dawn effect, which is what we're talking about next, is they do a blood sugar check between 2 and 4 a.m. And what they're looking for is if they've got the Somogyi effect where their body is giving them is causing an increase in their sugar based on too much insulin given, then they will have a blood sugar of 60 or less, 2 to 4 a.m. So what we need to do is either decrease their insulin dosage or have a bedtime snack. And that's all going to be dependent on the physician team and then patient individualized body system. You may see the try one and that doesn't work, and so they try the other. If they decrease the evening insulin, their blood sugar has spiked and stays high, they need to then just change to a bedtime snack. The other effect is called the dawn phenomenon. And so the difference here is that they have hyperglycemia upon waking, which is the same as Somogyi effect, but the difference here is that the amount of insulin they are getting is not enough to cover some release of hormone during night, especially growth hormone and cortisol, especially in the adolescent years. That happens, we know that our hormones, and you'll learn more about that in the endocrine discussions in adult 2, circadian rhythms do play a part in hormone distribution and release. And so in the dawn phenomenon, we're seeing cortisol and growth hormone are released overnight, which causes a spike in the blood sugar. And so this patient's blood sugar, 2 to 4 a.m., is going to be high, and they are going to need increased insulin dosage before they go to sleep at night to cover this effect. And again, most often seen in the growth years, so teenage years. So again, this is talking about oral agents. Metformin, and remember, is that first line of treatment for type 2 diabetes after they have failed diet and exercise, usually for 6 months. So we continue to see hyperglycemia and be on diet and exercise treatment for 6 months. We add an oral antidiabetic. Now, the most important thing that we need to remember about metformin as nurses is that it does react with, it can cause an increase in their creatinine levels while it's being, I just lost my word, excreted, while it's being excreted. So it causes a little ding to the kidneys. And then during surgery or any radiologic procedure where they're going to get contrast dye or contrast medium, it can definitely cause increase in their, that excretion of that contrast dye can also damage the kidney. So they need to stop metformin 1 to 2 days prior to surgery. We say 48 hours prior to surgery and 48 hours after. Okay, 48 hours. And then not to use them if they have kidney, liver, heart disease, or excessive alcohol use. And then to take it with food to minimize their GI upset. Biggest thing you're always going to see on NCLEX here is to stop it before procedures and surgery. That's a real big one. The gliptins, again, we start with the big UINs, metformin, and then we can add oral antidiabetics beyond that. And so this one is does two things. It not only reduces the glucose produced by the liver, but it also increases the insulin release from the beta cells in the pancreas. So the hard part about this is that because it is causing the pancreas to work in a bit of overdrive. It can lead to pancreatitis, and patients can have allergic reactions to it just like any other drug. So again, there are some injectable agents. These aren't insulin injectables, but they are, they affect the body, like stimulating the release of insulin from beta cells or decreasing glucagon secretion, slowing gastric emptying, which then provides them with a fuller feeling so they don't take in as much glucose. So depending on the type of insulin that they are non-insulin injectable they're using, again, most often this is something that they're going to be giving to patients with type 2 in conjunction with orals, or occasionally it is specific to decreasing glucagon secretion and slowing gastric emptying. Some of them do specifically just that. Then we can't see it used in type 1. So with type 1 and type 2, there are some nutrition things that we need to consider. Specifically with type 1, there's not a problem with them overeating. There's not a problem with them inappropriately eating for the most part. And there is no food that a patient with type 1 diabetes can't have. We are simply going to act as their broken pancreas by giving them insulin. So they can have whatever they want. They should eat a healthy diet in moderation like any other person. But we don't tell a patient with type 1 diabetes that they can't have ice cream, they can't have pizza, they can't have sugary drinks or sodas. We just need to cover it with insulin if they choose to have it. At one time, they restricted patients with type 1 diabetes diet to try and avoid any types of sugar. And that was psychologically not good for those patients. And so we have really worked towards helping them to live their life to the fullest potential they can. There is no cure for type 1 diabetes. And so we want to let them live optimally through health. We want them to choose good, nutritious foods, but we don't want them to miss out on those social aspects. So especially in those teenage years, if they're told that they can't have the foods that all their friends are having, they're more likely to stop using their insulin altogether. We already deal with that because when they are teenagers and have chronic illness, they struggle with wanting that feeling of normal. So by giving them some of that power back, by allowing them to eat whatever they want to eat, and then just making sure that they know how to appropriately cover what they've eaten, it gives them that feeling of power and allows for psychosocial health. Type 2 diabetes, on the other hand, can be cured through diet and exercise. So we do want to have significant diet modifications for a patient with type 2 diabetes. The other thing that we know about type 2 patients with type 2 diabetes is that they are at much higher risk for other comorbidities. Often they are obese, and so they also have hypertension and they have cardiovascular disease. And so we do a lot of diet modification with a patient with type 2 diabetes to try and get them on a more balanced diet. Okay. So again, we want to make sure that they're getting a rounded meal of carbs, fats, proteins. All right. We're going to want to make sure that we're using healthy fats rather than polysaccharide fats. Alcohol actually will interfere with the breakdown of glucagon to glucose, which can cause hypoglycemia. So if the body is not able to produce glucose, but we're providing insulin, or the body is providing insulin, then we can definitely see hypoglycemia. So alcohol we want to limit for all patients with diabetes type 1 or type 2. 2 drinks per day for men, 1 drink per day for women is good moderation. It helps to avoid that excessive. So it's really important to understand that binge drinking has a higher risk than just beyond alcohol poisoning, which we say for someone without diabetes, they can have alcohol poisoning and hypoglycemia. So very important that we talk with them about modification of alcohol consumption. So teaching patients how to count carbs, we talked about they're going to have probably an XY scale where they're not only correcting their blood sugar that's outside of normal, but also providing the body with enough insulin to cover the amount of carbs they're about to intake. More often than not, you see a 15-to-1 ratio. So they should get 1 unit of insulin for every 15 units or every 15 grams of carbs intake. Now that can be adjusted based on the provider and the patient, sometimes 120 or 130, but 1 to 15 is the base. And that's the one that you're going to usually see being tested for you guys on NCLEX. And so how do we count it? Well, there are all sorts of charts out there that tell you exactly how many carbs per item. So a medium apple is a certain number of carbs. The fun packs of Skittles that you get at Halloween, that's 15 grams of carbs. You can get online and there's carb counters everywhere. And so that's what patients will use is a specific carb count. Whichever one they choose, that's the one they stick with. And it literally lists out all foods. A slice of bread is 15 grams of carbs, so specific to that. And they just take whatever they're eating and add up all the carbs. And that's what they're going to use for their scale.
I know. Sorry, I was gonna say when I was in the hospital, we did that for one of the patients I had, and like on the food tray, it gives you like a sheet of paper with all the carbs, and we had to like calculate it.
Yes, an average meal is typically somewhere between 40 and 60 carbs, typically. Okay, and then exercise. So talking about patients with type 2 diabetes, we can't cure that type 2 diabetes through diet and exercise if it's related to obesity. If increases in adipose tissue is causing insulin resistance or the inability for the pancreas to release insulin properly, by getting rid of excess adipose tissue, we can stop the problem. So they call it curative. Diet modification, exercise modification, and weight loss that can cure type 2 diabetes. There is nothing you can do for type 1. No amount of diet or exercise is going to cause a pancreas that no longer produces insulin to stop producing. That's a disease process at the beta cells themselves versus something in the typically adipose tissue causing a reduce in the way that insulin is used. We can decrease insulin resistance through exercise. It actually causes more of an affinity for glucose cells to attach to glucose, so exercise alone. And that can actually occur for up to 48 hours after the exercise. We see this as the problem actually in our patients with type 1. So my students would they would eat breakfast and then go to the gym. And they would check their blood sugar and find that they would have symptoms of hypoglycemia. Well, that exercise along with their breakfast and insulin caused them to have a low blood glucose. So for some of my students, I had them check their glucose before they went to gym. And for some of them, we had a snack. And for some of them, we actually reduced their morning insulin dose because that combined with the exercise was enough to cause hypoglycemia. Which is the effect we want with patients with type 2, but can be dangerous in our patients with type 1. So it's very important to remember that insulin resistance is decreased during exercise, so their blood sugar is going to drop. And for our patients with type 1 diabetes, that means the insulin we give them is going to be used more effectively, and they're going to have blood sugar drops. Okay. And then what kind of exercise regimen do we recommend? 30 minutes, 5 days a week of some sort of cardio, and then 3 days a week of resistance training. That's specifically for our type 2s. So there are complications for diabetes that can result in these ulcerations as well. We talked about hypoglycemia, and that's defined as anything less than 70. Angiopathy, we can see changes to the vasculature, and so they are at increased risk for cardiovascular disease, stroke, neuropathies, retinopathies. Neuropathy specifically is that pins and needle sensation. So the ability for their ability for sensation is affected through changes through high blood sugar, continuous high blood sugar. And this is an over time situation. One high blood sugar will not give them a neuropathy. This is a hemoglobin A1C that's greater than 6.5 for months, years. These are slow, insidious changes that we see more often in type 2 than type 1, because type 1 typically tend to have pretty good control, because we can control the body's not producing insulin, we're producing it on the outside, and therefore we tend to see a better control of diabetes as long as they're adherent to their medication regimen and their treatment plan. So one high blood sugar does not make these changes. It's over time. Very important that you recognize that. A patient whose blood sugar drops below 70, their brain is not getting glucose. Glucose is required by every cell in order to function properly. A patient who has a blood sugar that drops low, significantly low, can be deadly. Low blood sugar is dangerous. High blood sugar is concerning. So keep that in mind. So if I say a patient's blood sugar is 400, okay, treat, give them some insulin. But if I say my patient's blood sugar is 20, that's an emergency. Okay, it's important that you make that distinction. And when we're treating hypoglycemia, do you guys remember that from pharm? What are the things that we do to treat hypoglycemia?
Glucagon or D50.
Yeah, so glucagon if they're at home, and glucagon given to the patient causes the liver to create glucose, so we can increase blood sugar and provide glucose to the brain. D50 is just sugar, so patients don't carry around big old 50 mil syringes D50. That's what we have available just in the hospital. So that's those two things. What if and when specifically do we use those two things? There's a very specific time. When their sugar is low, obviously, but also if they're not conscious. Anytime we can treat a patient with food first, we will. So if they are conscious and able to swallow, then we're going to use a sugar source. So juice, we're going to use glucose tabs. We might use, they have like a gel, glucose gel. And so the good thing about that is that those are going to give you a gradual increase of your blood sugar, especially if we follow it along with a good protein that helps then to keep that sugar from having a sugar crash. Glucagon and D50 raise it immediately. Like life or death, they're going to die if we don't. Their blood sugar is going to be 1,000. That's not dangerous, but it's less optimal. So if they're awake, we're going to try feeding them first. Does that make sense? So neuropathies, the biggest thing about neuropathies is we are concerned for their inability to feel, and these foot ulcerations are really a big concern for our patients that have diabetes. So we talk with them very specifically about always having protection for their feet, wearing shoes that are not open-toed, that are sturdy, except for when they're in bed. And so now they make rubber-soled slippers, and that's okay in the evening times, but they're up and out, either in your house or out in public. Actual shoes with covering and soles that are good and supportive are really important. What we see often is they step on something. They step on a nail, they step on glass, they step on something and don't know that they've done it because they can't feel their feet anymore from the neuropathy. And that's where these ulcerations set in. They get an infection. Also, patients with diabetes have high blood sugar, just as a general rule, and that's what bacteria likes. It likes a sugary environment. So they're more prone to infection and poor wound healing. So not only do we want to protect the soles of their feet through good soles on their shoes, but also from them walking into something, stubbing their toe, dragging their foot. I know everyone has probably done it, at least that's where you stub your toe. they won't feel it. And so they are at higher risk of infection and poor wound healing. So them protecting their feet is also super important, and tends to be an NCLEX question. Okay. And then just overall, they're at a higher risk for infection again, because they have higher sugar, and that's what bacteria like. That's the kind of medium bacteria like. So we talked to them about preventive measures, flu and pneumonia vaccines, avoiding sick people, trying to stay out of public when we're having outbreaks, and then just good hand hygiene. Good hygiene overall. The last two things we're going to talk about, make sure I'm not, oh, you know what, it's lunchtime. We've got 3 slides left to go. Let's, if you guys don't mind, we'll just get through these slides and then we'll start back a few minutes later. Is that okay with everybody? Okay. So 2 things that we're just going to briefly touch on, diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic, and that is HH. And we're going to talk about those 2 just briefly. You're going to get deeply into these critical care, but we want to touch on here because we're talking about diabetes. So DKA is more often found in type 1. We talked about this earlier, and this is where they have the inability to use glucose for energy. So the body then begins to break down fat and protein. And when that happens, that produces ketones, which then changes the acidity level within the body, and it can be life-threatening. This is often how we diagnose type 1. They come in with this. They come in with a blood sugar that's high because we don't have insulin being able to use, and they have ketones in their urine. And not too infrequently, they also have Kussmaul's respirations, which is that deep, rapid breathing, and that is their body trying to get them out of acidosis. Ketosis becomes acidosis, and it's a metabolic problem, and so it's going to try and correct itself through respiratory means, and so it's going to be trying to blow off that extra CO2, so that we can get back to a metabolic state. And so a lot of times we see this is precipitated by infection or illness, or just undiagnosed diabetes, because we know that when there's infection presence, then the body's natural resources create cortisol to try and fight off infection and inflammation, and that raises our blood glucose levels. Does anybody remember why increases in steroids or cortisol in the body increases hyperglycemia or increases blood sugar? It actually affects insulin resistance. Insulin is not able to be taken by the cells readily. With glucose, connected glucose, there's a blockage between those 2 connections with steroids and cortisol. So that's where you can see it in type 2. Okay, and so what are we seeing with them? They are severely dehydrated. The body there's glucose sitting in the vasculature, so that causes cell diuresis that pulls water from the cell. Remember, the body is going to try and stay in homeostasis all times. So if there's a high concentrate of something within the blood that shouldn't be there, water is going to follow to try and decrease that. Serum osmolality is going to try and decrease that imbalance. So they will become significantly dehydrated. They're going to show signs of they're going to show signs of hyperglycemia, like lethargy and weakness and nausea and vomiting. They'll have Kussmaul respirations. They have a sweet, fruity breath, kind of like juicy fruit gum. If anyone's ever smelled that, that's what their breath smells like. And that is the acetone that's being released into their blood system. Blood sugars are going to be better than 250. The students that I've seen in DKA, they were high. The blood glucose monitor couldn't tell me how high it was. So usually they go to about 500 and then they just say high, like you're too high. We just need to fix this. But they're usually greater than 250, anywhere up to 1,000, depending on the patient. Their pH is going to be significantly low related to that acidosis, and their bicarb is going to be low as well because it's metabolic. And then they're going to have ketones in their urine. So hyperosmolar hyperglycemia syndrome, HHS, we actually see this more often than in patients with type 2 and more often in patients who are older than we do in patients that are younger or type 1. So it's less common DKA. It is a life-threatening medical emergency similar to DKA. The main differences here is that they have a significant increase in their serum osmolality. The blood glucose levels are much higher, but their ketones are normal, not. And really what's going on here is they have significant dehydration, and it's either because they forget to drink or they just physically can't drink enough, and that is what leads to this. So that dehydration is what causes that significant change in their serum osmolality. It's not so much a lack of glucose and insulin distribution. It's more about dehydration. So they're very similar, and the way you tell the difference is kind of looking at their age. Again, it's going to occur more often in the elderly. It's going to be seen probably more often in a type 2 than type 1, but it can be in either, and there's no ketones. So serum osmolality high, ketones absent. So that's kind of a little picture for you. What's the difference here? They're both hyperglycemic, usually higher hyperglycemia in HHS. They're not acidotic in HHS, and they don't have ketones. So, questions about that? I will say the treatment for both of those conditions is going to be fluid replacement because they both cause significant dehydration. So fluid replacement is going to be your number one treatment. Okay, so let's come back at 1:15. We'll give you a few extra minutes since I held you over for lunch. And we will finish up with PVD and then talk about and go through our NCLEX questions. Let's see, make sure I got that. Rachel says, do that HESI case study for diabetes.